Hi everyone, this presentation is about pediatric vaccinations. I hope you enjoy it. Immunization is one of the most effective preventive health measures. The number of cases of most vaccine-preventable illness in the United States declined by more than 90% after routine childhood immunizations were introduced. Vaccination programs not only directly benefit the immunized child, but they also help create community immunity by protecting children who are too young for immunization and persons with contraindications to vaccines. Here we can see a routine immunization schedule. Vaccines are recommended at a specific age for two different reasons. One, when the vaccine will work best with the child's immune system, and two, when the child needs the protection the most. So let's dive into it. Let's start with hepatitis B prophylaxis. The risk of perinatal transmission among infants born to hepatitis B surface antigen positive mothers is as high as 90% without immunoprophylaxis. As we can see in this graph, the risk of chronicity is much higher when the infection occurs at birth than when acquired later in life. Also, 25% of these individuals will die prematurely from cirrhosis or liver cancer. This is why hepatitis B is the only vaccine administered at birth. Hepatitis B prophylaxis includes the hepatitis B vaccine for all newborns and hepatitis B immunoglobulin for newborns whose mothers are hepatitis B surface antigen positive or whose antigen status is unknown. In the United States, the timing of the first dose of hepatitis B vaccine and the need for hepatitis B immunoglobulin are determined by the mother's hepatitis B surface antigen status, and the infant's gestational age, and the infant's birth weight. Now let's review all the different possible circumstances. If the mother's antigen is negative and the birth weight is more than 2 kilos, the first dose will be administered within 24 hours of birth, a second dose at age 1 through 2 months, and a third dose at age 6 through 12 months. If the mother's antigen is negative, but the birth weight is less than 2 kilos and the infant is medically stable, the infant is immunized at 1 month of age or at hospital discharge if discharge occurs before 1 month of age, followed by 2 additional doses at 2 and 6 months. If the mother's antigen status is unknown and the birth weight is more than 2 kilos, the first dose should be administered within 12 hours of birth, while testing the mother to determine her antigen status. If she is found to be positive, immunoglobulin should be given by 1 week of age. If maternal status remains unknown, immunoglobulin should be administered at hospital discharge or within 7 days, whichever occurs first, plus 2 additional doses at 1 and at 6 months. When the mother's antigen status is unknown and the birth weight is less than 2 kilos, the infant should receive hepatitis B vaccine and immunoglobulin within 12 hours of birth if maternal status cannot be determined by that time or if it's positive, plus 3 additional doses at 1, 2, and 6 months. If the mother's antigen is positive, vaccine and immunoglobulin should be administered regardless of birth weight. Infants who receive appropriate immunoprophylaxis may breastfeed immediately after birth. Just like in the previous scenarios, if the baby's birth weight is less than 2 kilos, he will require 3 additional doses. Otherwise, only 2 additional doses are required. Testing for hepatitis B surface antigen and antibody should be performed at 9 and 12 months of age. If at any point the infant results hepatitis B surface antigen positive, he or she are considered infected with hepatitis B. If the infant's antigen is negative and antibody titers are 10 or higher, the infant is protected against hepatitis B virus, and no further doses or testing is necessary. The last scenario is an infant whose antigen is negative and the antibodies remain lower than 10. In this case, the infant is considered a non-responder to hepatitis B vaccine and is susceptible to the virus. Now let's talk about diphtheria, tetanus, and pertussis vaccine. Let's first review some of the terminology. DTaP vaccines must be distinguished from Tdap vaccines, which generally are used for a single booster dose during adolescence or adulthood. DTaP vaccines typically contain more diphtheria toxoid and pertussis antigens, and may contain more tetanus toxoid than Tdap vaccines. DT whole cell pertussis vaccines are no longer available in the United States, but are used elsewhere in the world, usually combined with hepatitis B and Haemophilus influenza in a pentavalent vaccines. Also, DT is no longer available. In the United States, 5 doses of DTaP vaccine are recommended between 6 weeks and 7 years of age. The childhood doses are routinely recommended at 2 months, 4 months, 6 months, with a minimal interval of 4 weeks. The 4th dose is given between 15 and 18 months. The minimum age for the 4th dose is 12 months and should be given more than 6 months after the 3rd dose. The 5th dose is given between 4 and 6 years and should be given more than 6 months after the 4th dose. The 5th dose, however, is not necessary if the 4th dose was given at 4 years of age and more than 4 months after the 3rd dose. An adolescent booster dose of Tdap is recommended at 11 through 12 years of age. Thereafter, booster doses with either TD or Tdap are recommended every 10 years. In the United States, 2 DTaP vaccines are available for the first 5 doses in children younger than 7 years of age. These are the Daptocel and Infandrix. The main contraindications include anaphylactic reactions to diphtheria, tetanus, or pertussis containing vaccines, and encephalopathy within 7 days of administration of a previous dose of the vaccine without another identifiable cause. Precautions for administration of DTaP include developing of Guillain-Barré syndrome less than 6 weeks after a previous dose. Although there have been case reports of Guillain-Barré following tetanus toxoid containing vaccines in adolescents and adults, an increased risk of Guillain-Barré following DTaP immunization has not been observed in children. Also, a history of Arthus-type reaction after a previous dose of tetanus or diphtheria toxoid containing vaccine is a precaution. An arthros-type reaction is a specific type of immune complex-mediated hypersensitivity reaction characterized by severe pain, swelling, induration, edema, hemorrhage, and occasionally necrosis at the injection site. It is recommended to defer vaccination until more than 10 years after the most recent dose of tetanus toxoid-containing vaccine. Also, moderate or severe illness with or without fever on the day of the immunization is a precaution to take. In this case, immunization should be administered upon recovery. An additional precaution for DTaP is progressive or unstable neurologic disorder, including infantile spasms, uncontrolled seizures, or progressive encephalopathy. DTaP should be deferred until the neurologic status is clarified and stabilized. Let's continue with Haemophilus influenza type B. This was once the most common cause of bacterial meningitis and a frequent cause of other invasive diseases like epiglottitis, pneumonia, septic arthritis, bacteremia, particularly in early childhood. In randomized trials, HIV conjugate vaccines prevent more than 95% of invasive HIV diseases. These are inactivated vaccines and are administered intramuscularly. The current recommendation is to immunize all infants with a Haemophilus influenza type B conjugate vaccine. This vaccine is routinely recommended at ages 2, 4, and 6 months, with a booster dose at age 12 through 15 months. Chemoprophylaxis is important to prevent secondary cases of Haemophilus influenza B disease, which refers to an illness occurring within 60 days of contact with a patient. Rifampin is recommended because it achieves high concentrations in respiratory secretions and eradicates nasopharyngeal carriage in more than 95% of carriers, thereby reducing the risk of developing invasive diseases and interrupting transmission. Who should receive chemoprophylaxis? First, the index patients who are treated with an antibiotic other than cefotaxime or ceftriaxone and are aged less than 2 years should receive rifampin prior to hospital discharge. Because cefotaxime and ceftriaxone eradicate HIV colonization, prophylaxis is not needed for patients treated with either of these antimicrobials. Next, household contacts. Rifampin chemoprophylaxis is recommended to all household contacts in households with members aged less than 4 years old who are not fully vaccinated, or members aged less than 18 years who are immunocompromised regardless of their vaccination status, and households with a child less than 12 months of age who has not completed the primary Haemophilus influenza B series. Last, in childcare settings, prophylaxis is recommended when 2 or more cases of invasive HIV disease have occurred within 60 days and unimmunized or under-immunized children attend the facility. It should be prescribed for all attendees regardless of age or vaccine status, and for childcare providers. Rotavirus is the most common cause of severe gastroenteritis in infants and children around the world. Rotavirus vaccines are highly effective in preventing rotavirus gastroenteritis and associated hospitalizations and healthcare utilization. 2 live attenuated oral rotavirus vaccines are licensed for use in the United States. The vaccines have similar efficacy and safety, and neither vaccine is preferred over the other. RV5 requires 5 doses at 2, 4, and 6 months, and RV1 requires 2 doses at 2 and 4 months. Contraindications to rotavirus vaccine include allergy to any of the vaccine ingredients, severe combined immunodeficiency, certain other primary or secondary immunodeficiencies, and history of intussusception. Latex-free presentations are available for infants with a history of severe allergic reaction to latex. Conditions that are precautions for administration of rotavirus vaccine include immunodeficiencies other than SIDS, moderate or severe illness, certain pre-existing or acquired gastrointestinal conditions like congenital malabsorption syndromes, Hirschsprung disease, short bowel syndrome, or previous bowel surgery, because there is one case report of pneumatosis intestinalis following rotavirus vaccination in a 3-month-old with a short bowel syndrome. Also, spina bifida or bladder exstrophy. Infants that have this condition have a high risk of developing latex allergy. So, to minimize the latex exposure, some experts suggest that latex-free presentations should be used for such infants. However, the ACIP recommends rotavirus vaccinations even if latex-free presentations are not available because the benefit of vaccination is greater than the risk of sensitization. Let's talk about pneumococcal vaccination now. Streptococcus pneumonia is a leading cause of serious illness in children. In the United States, the ACIP recommends routine immunization with either the 13-valent PCV or the 15-valent PCV administered intramuscularly. Children should receive the vaccine at 2, 4, 6, and at 12 through 15 months of age. The ACIP recommends PPSV23 immunization for children older than 2 years old at high risk of infection with pneumococcal disease. Target high-risk groups include children older than 2 who are immunocompromised or have a cerebrospinal fluid leak, cochlear implant, or certain chronic diseases. The risk is particularly high in children with sickle cell disease. The recommended schedule in high-risk children varies with age and pneumococcal vaccination history. The following algorithms are available to guide the approach. Immunization against poliovirus infection represents one of the world's great medical achievements. The last cases of paralytic poliomyelitis in the United States occurred during a small outbreak in an unvaccinated religious community in 1978. Inactivated poliovirus vaccine is the preferred vaccine for developed countries because it can be combined with other routine childhood vaccines and it does not cause vaccine-associated paralytic poliomyelitis, which occurs as a result of reversion of an attenuated viral strain to a neurovirulent strain. Live attenuated oral poliovirus vaccine has been associated with rare cases of VAPP in vaccine recipients and their contacts. However, OPV remains an important tool for control of poliovirus transmission in the developing world because of low cost, ease of administration, induction of mucosal immunity, and low risk of transmission of OPV viruses from OPV vaccinated children to their non-immune contacts. The recommended schedule for poliovirus vaccine is at 2, 4, 6 months and at 4 through 6 years of age. Let's move on to influenza vaccine. Annual immunization is necessary because immunity declines after immunization. Influenza immunization is recommended annually for all children 6 months of age and older. It is an inactivated vaccine, and for children aged 6 months through 8 years, the number of doses varies with the past history of influenza immunization. So 1 dose if they received more than 2 doses of influenza vaccine separated by 4 weeks. The 2 doses need not have been administered in the same season. Otherwise, they will receive 2 doses. Our next vaccine is MMR. Measles, mumps, and rubella infections may have serious complications like encephalitis, orchitis, ophthalitis, or congenital rubella syndrome. The routine schedule, either for MMR vaccine or MMRV, including varicella virus vaccine, consists of 2 doses, the first at age 12 through 15 months and the second at age 4 through 6 years. Adverse effects of MMR and MMRV are more common with the first than the second dose. They include fever, rash, lymphadenopathies, joint complaints, hypersensitivity reactions, immune thrombocytopenia, and seizures. In children younger than 48 months, or with a personal or family history of seizure, it is recommended to separate MMR and varicella vaccines. It has been proved that routine immunization with 2 doses of varicella vaccine is at least 90% effective in preventing primary varicella infection and 99% effective in preventing severe varicella disease. In children, the 2 doses are typically administered at age 12 through 15 months and at age 4 through 6 years. In adolescents older than 13 years old and adults, the 2 doses are usually separated by 4 to 8 weeks. Varicella vaccine is generally well tolerated, however, local injection reactions, rash, and febrile seizures have been reported. Transmission of vaccine virus is rare and generally occurs in the context of a varicella type rash. People who develop a rash after varicella vaccine should refrain from physical contact with people who are susceptible to varicella, particularly those who are immunocompromised, until the rash has resolved. Let's move on to hepatitis A vaccine. Hepatitis A infection is usually self-limited and treatment consists on supportive care. 2 doses of hepatitis A virus vaccine are routinely recommended between 12 and 24 months. The doses should be separated by at least 6 months. It is also recommended that children and adolescents aged 2 to 18 years who have not previously received hepatitis A vaccine should receive 1 dose. For infants aged 6 to 11 months who are traveling internationally, vaccinations should be administered. The travel-related dose should not count towards a routine 2-dose series. Now let's discuss some of the most important adolescents vaccinations. In first place, we have the Tdap. So a dose of tetanus, diphtheria, and acellular pertussis vaccine is routinely recommended at age 11 through 12 years. Tdap is an inactivated vaccine and it is administered intramuscularly. Then we have meningococcal vaccine. In the USA, all college students less than 21 years of age should have a documented dose less than 5 years before enrollment. Routine immunization of adolescents has been associated with decreased incidence of meningococcal disease in adolescents. Two meningococcal vaccines formulations are available and include the quadrivalent meningococcal conjugated vaccines for serogroups A, C, W, and Y, and a monovalent vaccines for serogroup B. All available formulations are inactivated. For healthy adolescents aged 11 through 18, it is recommended routine immunization with MenACWY. The recommended schedule is a first dose at age 11 through 12 years and a booster dose at age 16. The booster dose is necessary because the antibody response wanes within 5 years. Individuals immunized at age 11 or 12 years may have decreased protective immunity by age 16 through 21, when their risk of disease is greatest. Adolescents who receive their first dose at more than 16 years of age do not require a booster dose unless they become at increased risk of meningococcal disease, like traveling to an endemic area or undergoing a splenectomy. And last but not least, human papillomavirus is a sexually transmitted pathogen that causes anogenital and oropharyngeal disease in males and females. Vaccination with human papillomavirus vaccine provides a direct benefit to female and male recipients by safely protecting against cancer in the oropharyngeal, vulvar, vaginal, cervical, penile, and anal that can result from persistent high-risk HPV infection. HPV vaccines have been developed to protect against acquisition of HPV infection and development of subsequent HPV-associated disease. 3 human papillomavirus vaccines have been developed. In the United States, however, only the 9-valent vaccine has been available since the end of 2016. HPV vaccine should be administered at age 11 to 12 years of age. However, it can be administered starting at 9 years of age. For adolescents and adults aged 13 to 26 years who have not been previously vaccinated or who have not completed the vaccine series, a catch-up vaccination is recommended. In general, the optimal time for HPV immunization is prior to an individual's sexual debut. And with this, we have finished our presentation of pediatric vaccinations. Thank you.